Hello students. Welcome to Concepts of Care for Patients with Conditions of the Central Nervous System, especially the brain. Okay, so the most important concepts for this chapter are going to be cognition, mobility, and the interrelated concept for this chapter is pain and infection. So dementia, Alzheimer disease, is the first one that we are going to review in this chapter. Dementia sometimes refers to as chronic confusional state or syndrome. Is a chronic confusional state. Remember that. It's a general term for progressive loss of brain function and impaired cognition. So you have impaired cognition and chronic confusional state or syndrome. Alzheimer's disease is a clinically considered the most common type of dementia that affects people older than 65 years old. So you have dementia, that's the big umbrella, and under dementia you have Alzheimer's disease and you have vascular dementia, which is a multi-infarct dementia and results from strokes or other vascular disorders that decrease blood flow to parts of the brain. So vascular dementia is related to circulatory issues. Okay, recent research has focused on Alzheimer's disease. We're going to call it AD from now on, as pathophysiologic process rather than a type of dementia. That's the difference. Biomarkers, specifically abnormal levels of beta amyloid and tau proteins, can be used to diagnose AD in the preclinical phase before dementia symptoms occur, meaning before the chronic confusional state and impaired cognition occurs. Not every individual with preclinical AD develops dementia. Okay, so dementia is not a normal physiologic change of aging, as we saw in the previous chapter, and that's good to know. It's not a normal. Okay, in the presence of AD and other types of dementia, these normal changes are greatly accelerated, causing further reductions in brain weight. COVID-19 infection also accelerated AD pathology and symptoms during the pandemic. Marked atrophy of the cerebral cortex and loss of cortical neurons result in the classic symptoms associated with AD dementia. So if you need a refresh, you need to refresh your knowledge about the cerebral cortex, you can go to the previous chapter. There are videos. That's why I put videos, so you get familiarized instead of just learning facts or memorizing names or structures. You can see the video so you understand much better. Let's analyze. I'm going to put a video about neurofibrillary, but let me first state microscopic changes in the brain found in people with AD include neurofibrillary tangles, amyloid-rich neuritic plaques, and vascular degeneration. So we are going to watch the video about the neurofibrillary tangles. Okay, let's watch this.
As part of the cytoskeleton, microtubules play an important role in the formation of cell shape and transportation of important nutrients within the nerve cells. In healthy neurons, there is a natural protein called tau protein, which maintains the integrity of cellular microtubules. However, in Alzheimer's disease, the tau proteins are abnormally hyperphosphorylated. This hyperphosphorylation process makes tau proteins inactive. And as a result, the microtubule loses its natural integrity and starts to collapse. The hyperphosphorylated tau protein aggregates to form new pathological structures called neurofibrillary tangles, which distribute throughout body nerve cells.
Thank you so much. So these neurofibrillary tangles are composed of twisted fiber tissue containing abnormal amounts of the tau protein. And we saw how the tau protein forms other abnormal cells. They impair the ability of impulses to be transmitted from neuron to neuron. Neuritic plaques are composed of degenerating nerve terminals and are found particularly in the hippocampus, an important part of the limbic system. Also, you can go back to the previous chapter, you can watch the video related to this part. Deposited within the plaques are increased amounts of an abnormal protein called beta amyloid. These proteins has a tendency to accumulate and form the neurotoxic plaques found in the brain that impair neuronal transmission. I want to add something else here. Now, what causes hyperphosphorylated tau? She mentions that this hyperphosphorylation in the tau, right? Multiple etiological factors cause abnormal hyperphosphorylation of tau via various pathways, including the amyloid beta, dysregulation of phosphorylation, and impair brain glucose metabolism. I'm gonna keep that thought. So I'm going to think about right now our diabetic patients and how they are in risk for developing Alzheimer's disease, right? Because of the improper glucose metabolization. Think about that. So these can cause the tau and the presence of the beta amyloid in the Alzheimer's disease. Although vascular degeneration occurs in the normally aging brain, its presence is significantly increased in patients with dementia. Okay. Now we are going to analyze the causes of the Alzheimer's disease versus the vascular dementia, and this is good to know. This is good to know. So Alzheimer's disease, basically what the theory is telling us, even though the research is focusing on the beta amyloid and the tau, okay, basically the theory is confirming that it's a genetic and environmental factors and possible viral factors, okay, for Alzheimer's. While vascular dementia is basically strokes, and other vascular disorders that decrease blood flow to the brain. Okay, this is good to know. Also, let's see the risk factors. Basically for AD, the females are in higher risk, over 65, with history or Down syndrome, traumatic brain injury. In the case of vascular dementia, patients over 65 years of age, history of diabetes mellitus, high cholesterol, myocardial infarction, atherosclerotic, hypertension, smoking, obesity. Right there, if you are right now analyzing and you stop right there, you can see that these risk factors are giving us the opportunity to make a list for prevention. So we need to get a better nutrition in order to lower our risk for hypercholesterolemia, to prevent diabetes, to prevent hypertension, we need to avoid smoking and obesity. Okay, so those risk factors right there are giving us the hint for prevention, even though it's not confirmed by science, but at least we can do our part. And the management basically is right now focused on medications, but we can add the nutritional part the exercise, and the stress management. In addition to the structural changes in the brain associated with these disorders, abnormalities in the neurotransmitter acetylcholine, norepinephrine, dopamine, and serotonin may occur. High levels of beta amyloid can reduce the amount of acetyltransferase in the hippocampus. The decrease in acetylcholine interferes with cholinergic innervation to the cerebral cortex. This change results in impaired cognition, recent memory, and the ability to acquire new memories. Because we need to remember that acetylcholine improve our cognitions, make us work better in terms to remember recent or past events, and is helping us in the ability to acquire new memories. I'm going to put a video later because we need to understand how the axon, the transmission of acetylcholine from one neuron to another neuron, is affected in this condition, and the participation of the acetylcholine inhibitors, cholinesterase inhibitors, are preventing the destruction of acetylcholine, and they are not reducing the disease, okay, but they prevent full destruction, and then they help with the disease progression, okay. Etiology and genetic risk. Age, gender, and genetics are the most studied risk factors. Age is strongly linked to the incidence of AD for people older than 65, and women are more likely to develop the disease than men. Okay, we know that. Also, recent research is talking about that during menopause, increased serum follicle stimulating hormone, FSH, bind to the FSH receptors on neurons in the brain, activating the pathway that accelerates formation of amyloid plaques and tau formation. And this is producing the pituitary, okay? Also, and this is good to know, common risk factors for AD and other dementias includes cardiovascular disease, decreased hearing, smoking, and depression. Other risk factors for AD have been studied, including traumatic brain injury, environmental agents, inflammation. Let me tell you, obesity is the chronic state of inflammation. Okay, inflammation is basically obesity. Immunologic changes, and that would be the viral causes of the AD, excessive stress, and sleep deprivation. There is also a high incidence of AD in people who have Down syndrome. So we saw that, and that's good to know. All of you that are working on making a list for preventions, right? We need to know the preventing habits. We have to talk about I am sure you study nutrition, and they mention you about the Mediterranean diet. So we can prevent this disease following the MIND diet, which is the combination of the Mediterranean and DASH. And this can help improve cognitive function. Also the exercise, also how we can reduce risk factors. Although Alzheimer has a genetic component, research has shown that certain behaviors such reducing stress, managing blood pressure, and staying mentally active can reduce your risk. When they mention mentally active, means reading is a great exercise to keep the mind busy. So that's something you need to practice, okay? And suggest your patients to practice reading, for example. Please read by your own this patient-centered care related to the veteran health, and also the genetics, especially because here they are mentioning one genetic factor named apolipoprotein E, which is a protein that transports cholesterol, okay? This is not covered by your insurance, but you can pay extra to see if you have the genetic factor, right? And patients, they can access this information. Incidence and prevalence, there is a significant increase in both the incidence and prevalence of Alzheimer's disease after 60 years of age, although the disease may affect anyone older than 40 years, because the disease can present after 40, and you can start developing, the patient or someone can start developing the symptoms. So the symptoms are going to be more noticeable after 65. 1 in 9 people in the United States over 65 of age has AD. So, for example, here in class, we are 40 students, right? We are 41 people, including me. So basically 1 out of 9, right? Could develop the disease. That's something we need to think about. The statistics are very high. Okay, dementia and social determinants of health. So basically, Black individuals have twice the risk of developing AD or other dementias compared with whites. Hispanics have about 1.5 times higher risk. But look at these factors. These social determinants of health. For example, lower socioeconomic status, low educational level. We are very blessed to have the opportunity to learn about this. I will strongly recommend you to focus and study deep into these diseases now that you have the opportunity and time after your graduation. Basically, I'm sure you are not going back to the books. And when you learn this, it's not only for your patients, but it's also for your information, your personal health, and your family health, which is the most important. Okay, so read this, study this, make sure you understand every single detail. Performance of manual labor jobs. This population that are working in construction, for example, or doing any other activities, especially now that we have too many immigrants, they probably don't have enough food, so they don't have the appropriate food, right? The appropriate nutrition. Decreased social interaction or social isolation, increased stress. So you have to think about the population that could be at risk for Alzheimer's disease. Health promotion, disease prevention. There are no proven ways to prevent Alzheimer's disease. However, the medicine, right? They don't know how to prevent this. So they are giving us a list of medications for prescription to manage, but we can do our part with the proper nutrition, exercise, and stress management, right? And avoid alcohol, drugs. Many patients with Alzheimer's disease have other chronic health problems such as diabetes mellitus, and we saw the relationship with the tau protein, right, related to the poor glucose metabolism. Also, they have strokes, atherosclerosis. Maintaining a healthy lifestyle helps prevent these conditions and can assist in controlling them. Avoid smoking, alcohol, as I mentioned before. Teach patient about community resources that can assist individuals. So I gave you in the supplemental file, you have this link. It's called Shape Up New York. You're going to find Zumba classes for free in all boroughs. In every day, the schedule is very it's very interesting. You can have from classes and exercises for older adults all the way to high cardio exercises. It's very interesting. You can go, I gave you the website. Also, I gave you information about, there is another website in YouTube, another channel in YouTube that you can see a lady practicing how to walk, and she has different sessions. She has videos for 30 minutes walk, 1 mile block, walk, and is is amazing. Usually when I am home studying and I don't, for example, right now in winter, I don't go for walking, then I watch the videos, I stop studying, I start walking, watching the video, and they go back to study. Okay. And she has millions of views. Interprofessional collaborative care, recognizing the cues, the assessment is important. Physical assessment are necessary to differentiate AD from other possible reversible causes of impaired cognition. Yes, because impaired cognition could be maybe due to any trauma or any bacterial infections. So you need to do a physical assessment to differentiate. Some patients experience cognitive impairment as acute confusion, delirium. Patients who have dementia are at increased risk of delirium when hospitalized or admitted to an assisted living long-term setting. Okay, so when you use your old cards mnemonic, you can assess your onset, duration, progression, the course of the symptoms, the medications, if they are helping or not. Also ask for the current employment status, if they are able to do the ADLs, including cleaning, grocery shopping, if they can drive, prepare their meals. You can assess for all those factors. Physical assessment, signs and symptoms, stages of the Alzheimer's disease. This is very important and this is good to know. NCLEX alert. So we have basically three stages: the early, the moderate, and the late. So recall the AD, recall that this disease is a chronic progressive disease that has an overall predictable course. However, I have to mention that if a patient is on the earliest stage, not necessarily he is going to progress into the moderate. He can jump immediately to the late stage. All of this depends on the chronic condition, how the disease is managed, if he's getting the wrong nutrition, more stress, or different factors. This can make the disease to progress faster. So you need to be thorough on your assessment. Changes in cognition, you are going to assess for attention and concentration, learning, memory, speed of information processing. One of the first symptoms of Alzheimer is short-term memory impairment. New memory and defects in information retrieval results from dysfunction in the frontal parietal region, alterations in communication abilities such as apraxia, aphasia, anomia, and agnosia can occur. And I'm going to play some videos, very short videos, because this is the best way to learn as we see. So let's watch first apraxia, inability to form words or use objects correctly. Okay, let's watch this video now. What color you want?
Yellow.
Try again.
E.
Yep, say your whole word.
E.
E.
Yellow.
Nice. I like how you used your EQ to help you get yellow. Do it again. So that was apraxia, inability to find words. Now let's watch aphasia. Aphasia. Okay, here is the video. Aphasia, which is the inability to speak or understand. Aphasia.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing. Like here?
I'd like my change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them.
Good.
This girl was really good.
Okay, thank you. That was aphasia, inability to speak or understand. Now we're gonna go with anomia. Anomia, let me play the video. So anomia is the inability to find words. Anomia, inability to find words.
The wood with them. It saw.
Oh.
Have them in the garage. They are, it's called a, I have them in the garage. They are you cut the wood with them. It saw.
How is it?
Oh, it's saw. I can't state it. I know what it is, and I could cut the wood with it, and it's in my garage. And it's you also, when you go out and you want to stay out in the woods with people, you always take those with you. And it's not a knife, it's not a...
So you see right there, she cannot find the right word for that tool. So we saw apraxia, so far inability to form words or use objects correctly. Apraxia, that was the baby that couldn't form the word yellow, apraxia. Then we saw the aphasia, which is the inability to speak or understand. We saw the gentleman who was describing an event next to the water. Then we saw the anomia, is the lady who recently couldn't find a word for a particular tool used to cut wood, right? Now we are going to see agnosia, loss of sensory comprehension, including facial recognition. Agnosia, loss of sensory comprehension. Okay. I'm gonna look for the best part of this video.
Each one and how it is used. For a person with agnosia, this task can be very difficult. Notice how Greg not only looks at the toothpaste, he also feels the tube in his hand. He then makes a mistake by reaching for the comb rather than the toothbrush. He knows the object is not right for the task. It takes a few seconds for him to work this out. He then chooses the toothbrush correctly.
There you go, the toothbrush. Excellent. So, excuse me if I got the wrong information before describing the different alterations in communication abilities. It's kind of difficult to speak, play the video, read, but well, anyway, we got it right now. So now we are going to see the 3 stages of Alzheimer's disease. In the early stage, basically, they are independent in ADL. In the moderate, they become increasingly dependent in the ADL, right? And in the late stage, they are completely, totally dependent in ADL. So that's only one factor, right? You can go through and make the difference between early, moderate, and late stage. So for example, in the early stage, has mild impaired cognition and problems with judgment, and that's good to know, because in early Alzheimer's disease, right? You need to evaluate the mental status and short memory, asking, for example, what day is today? Remember that the problem is more noticeable with the short memory, okay, versus the long-term memory. Okay, let's continue with later stage, the patient loses all cognitive abilities. We know that. To more clearly identify the nature and extent of the patient's impaired cognition, there is a couple of tools that the neurologist is going to use. One is going to be the Folstein Mini Mental State Examination, MMSE, or also called the Mini Mental Exam, and also the Montreal Cognitive Assessment, MOCA. These both are used frequently, and they require that the patient be able to read. For the patient who cannot read or for a quicker screening test, the set test can be used. The patient is asked to name 10 items in each of 4 sets or category: fruits, animal, colors, and towns. Also, the clock drawing test. This is very fun, and I've seen it. They use this frequently. Does not require that the patient be able to read and is non-threatening to perform. So in LTC settings, long-term care facilities, the federally required brief interview for mental status is included as part of the minimum data set for nursing homes. Now we are going to assess the change in behavior and personality. If they become aggressive, have rapid mood swings, increased confusion at night or when the light is not adequate, sound downing, or in excessively fatigued patients, right? For some patients with dementia, emotional and behavioral problems occur with the primary disease. They may experience paranoia, suspicious behavior, delusion, hallucinations, and depression. So right there, you need to understand that we are talking about a very difficult disease, not only to manage, but we need to find the right caregiver for this type of patients. It's very important. This is one of the diseases that nurses are going to be very important in the care of these patients. Not only nurses, but family caregivers, okay? It's important to find the right person who has enough compassion and willing to clean and do ADLs for the patient in a very nice and loving way, okay? Changes in self-management skills, we need to find somebody to help them get dressed because the patients are going to have decreased interest in personal appearance. There's going to be problems in the selection of clothing, loss of bowel and bladder control, decreased appetite or ability to eat. So right there, the person who takes care of these AD patients must be really able to perform these activities with good intention and motivation. Okay, psychosocial assessment in the early stage, patient often recognize that they are experiencing memory or cognitive changes and may attempt to hide the problems. So the patients, they know what they are going through and recognize that they begin the grieving process because of anticipated loss, experience denial, anger, bargaining, and depression at various times. And we need to provide a lot of support, right? Assess patients who recently received a diagnosis of dementia for suicide risk. This is very important. We need to be very knowledgeable to be able to identify who is at risk for suicide. Usually the patients are going to start having, they're going to behave in a way that we are going to be able to see if they are having suicidal risk. Of particular importance is the need for an assessment of the patient's reaction to changes in routine or environment. For example, a hospital admission is very traumatic for most patients with dementia, and that's good to know. A patient admitted to hospital or long-term facility must be located in a room close to the nurse station, okay, to reduce this anxiety. Sexual disinhibitions is one of the most challenging symptoms for both family and staff members. We need to be aware and we need to understand this. Neuropsychiatric symptoms are common in patients with AD and increase as the disease progresses and aphasia increases. So we are going to right now go into the laboratory and imaging assessment. We first take the patient history, clinical presentation, and based on that, the provider is going to suggest the type of imaging. The most sensitive diagnosis tool to detect biomarkers for the disease is the amyloid positron emission tomography, the PET imaging. The patient is injected with a radioactive tracer that can highlight amyloid protein in the brain, and individuals who are at risk, high risk for developing AD have high amount of this biomarker. Also, an MRI may be performed to rule out other treatable causes of cognitive impairment. The CT scan typically shows cerebral atrophy, vascular degeneration, ventricular enlargement, and some other factors that are related to the disease. Genetic testing, specifically for apolipoprotein, the APOE is available but controversial for public use. The presence of this protein only indicates increased risk for developing the disease. So there are different genetic tests. Also, the amyloid beta protein precursor may be measured in patients in order to diagnose AD. A decrease in the patient's amyloid beta protein precursor in the cerebrospinal fluid supports the diagnosis because this protein tends to deposit in the brain and is not circulating in the cerebral spinal fluid, right? So we have the NCLEX, and this is good to know. It's good to double check on these questions and answers. The question says the nurse assesses a client with a diagnosis of Alzheimer's disease. Which of the following assessment findings would demonstrate the client has progressed to the moderate stage? And you can see that the right answers are forgets neighbor name, is unable to balance the checkbook, gets lost when traveling to familiar places, cannot identify time, place, and event. You can go back and review the table with the 3 stages to understand these answers, and it's very important that you get familiarized with the 3 stages. Okay, we're gonna have a break now, and then we are gonna come back with part 2 of Alzheimer's disease.